can start our discussion around this open debate about frontline CLL therapy, where either long-term BTK inhibitor therapy now is challenged by these time-limited treatment approaches. For which patients is which approach better? Are we moving away from long-term BTK inhibitor therapy? So when we think about 15 years ago, when we had chemoimmunotherapy, there was this concept of fitness that guided us to say, well, younger fit patients we can treat with FCR, intermediate with BR, and unfit patients were given chlorambucil with CD20 antibodies. Is that maybe the direction the field is going to go, that we say these more intense double or triple time-limited therapies are best suited for younger and fit patients who have low-risk disease features, and older, frail patients, maybe monotherapies are better? Is that how you see things are going, and is that your practice? Or is it driven by risk factors? Do we say high-risk patients who present aggressively, we want to continuously suppress their disease and we don't want time-limited treatment? So I thought maybe we can start the discussion around that, how you kind of approach it, how you talk to your patients about these possibilities and how you choose. Can we start with you?
Thank you. I think with the options that are available in CLL right now with very excellent results, it's always a challenge when we talk to patients about whether someone goes for a fixed duration therapy or whether someone goes for a continuous therapy. I think it's more to come, because previously the debate used to be whether you do a CD20 antibody with venetoclax versus a covalent BTK inhibitor, one being a time-limited approach versus one being a continuous approach. Now we are trickling more into including a BTK inhibitor plus a BCL2 inhibitor in the combination, even in fixed duration therapy, with or without even including the CD20 antibody. I think that discussion has really gone out in multiple different ways in multiple different directions right now. I think I still try to keep the discussion as whether a patient wants to have just a time-limited therapy where I just offer the options, as compared to someone who does not want a time-limited therapy because of lifestyle, comorbidities, age, and many other factors, where a continuous BTK inhibitor therapy is what we'll be talking about.
Thank you. Can we ask you too, for your opinion, Dr. Kafan? I'm not going to ask you because as a hematopathologist, I'll have some discussion around other topics.
So admittedly, I see mostly patients in the relapse refractory setting, but I have to say that in the front line, probably it's really matching the patient desires to the treatment realities, because it's not what they want, it's what really we can do for them also. So I think that what I find, I mean, the concept of any time-limited therapy is desirable, in my opinion. The cost and all of that come with it. I think the challenge with time-limited therapies right now is some of them have a fixed duration of treatment, like Amplify prescribed. Others are more complicated, like the UK FLAIR study, where you achieve MRD at 2 years, but you have to give 2 more years, and if it's 1, you give 1 more, and so on and so forth. So that gets more complicated. So I think that time-limited therapy continues to be, in my opinion, a big label, and we need to kind of refine it more. Now, I probably am going to as Dr. Sangabi, where we lag behind is really, if you look at all the guidelines for MRD utilization in CLL, it says not recommended in clinical practice. But how can you do time-limited therapy without having a well-established MRD assay to try to guide yourself? How do you guide yourself without that? So there is a dissociation there. And then do we go with MRD -4, MRD -6? I mean, the Europeans seem to push more the ERIC standards of -6. Here we're still talking -4. Is that still relevant in -4? So that's something.
Sure. Yeah, maybe we can have this MRD discussion. What is our practice at MD Anderson and other reasons to go beyond flow, like across the board, go to BCR sequencing?
Can you hear me?
Yeah.
Okay. So I think at MD Anderson, we're very privileged because we're doing both. So we are, continuing to do flow on a regular basis achieving a 10 to the minus 4 sensitivity, and then also using NGS or clonoSEQ to get deeper levels at around 10 to the minus 6. I think if we want to extrapolate from the ALL world, it's less MRD is always better, of course, but I just don't think we have enough data. We don't know that how different is 10 to the minus 4 versus 10 to the minus 6. So I think it goes back to what you were saying. It's at the expense of toxicity versus achieving a deeper remission. We are actively collecting that data. So.
Yeah. In my opinion, the sequencing approach to MRD testing these very deep remissions, it has two sides to that coin, because it creates in the patients and the physicians some hope that these patients are really going to have long remissions, but what in the end counts is the biology of the disease. If patients go into these deep remissions but have very aggressive disease, then that's not a guarantee for very long remissions. They're going to come out of these remissions sooner, and we saw that with ibrutinib venetoclax, with that combination. When we follow MRD levels in mutated versus unmutated patients, you see that unmutated patients lose deep MRD negative remissions faster than mutated patients. So it is I think a bit problematic to advocate that right now for every patient, because it's a bit difficult to say how to advise patients. Is that a stop point for treatment if they are MRD negative? Can we not stop if they are still positive? It depends on the disease biology. How do you feel about that?
So just kind of reeling it back to the original question about time-defined versus indefinite. If you, and there's data that shows this, if you just ask patients, you don't give them any details, you just ask them, do you want a therapy given over a defined period of time or just indefinite? Almost all say time-defined. And then there's obviously something that then takes the nearly 100% down to, when you look at what's actually being given to CLL patients, around roughly 15% ultimately are getting the ven-obinu approach. And I think there's some variance between, when a patient sees a specialist versus a general oncologist, because with CLL being an indolent malignancy, it's so much of it is still cared for out in the community. And so I think there's a lot of elements. I alluded to one. I find that a lot of patients, the barrier is the infusion center. They want to, once they start hearing about all the time with the obinutuzumab infusions, they just say, just give me the pill. And then some maybe it's the ramp up, but I feel like that's probably less of an issue. And one really nice thing I didn't get to on the Amplify study, there was no TLS whatsoever with the ven ramp up after the first couple of months of Acala. So you almost, I know they had to watch it on the trial, but you look at that data and you almost really feel like you don't actually need to monitor them that closely for the ramp up. So I think the combination will open the door to more people to get time-defined therapy. In terms of who it's best for, I think probably still for chromosome 17 aberration patients, that indefinite therapy seems to be the best. I mentioned the unmutated group. Maybe that's who you throw the obinu on for. And on the MRD side, it's very interesting. Right now, it's not on guidelines because it's just a prognostic marker at this point. We have no trial that tells us we can use it as a predictive tool. There's studies that are looking at that. I think probably the MAGIC trial will be the first to, at a large phase 3 level, use MRD as an actionable endpoint to either keep going with therapy or not. the FLAIR trial was very interesting, but it didn't really have like a solid comparator to judge whether, shorter duration was any better than extending the therapy. So it's hard to say. So I'd use clonoSEQ when I can. I think it's really nice to get that level of detail in the reports, and you can get multiple time points charted out as you order more tests over time. So that's nice. And then the idea of what's better, 10 to the minus 4, 10 to the minus 5, 10 to the minus 6. There is some pretty compelling data that if you get 10 to the minus 5 in the blood, that it correlates to 10 to the minus 4 in the marrow. So that's why the MAGIC trial used 10 to the minus 5 as the cutoff in the blood. The Al-Shawaf breakdown of CLL14 in a lot of different ways, they broke it down by 10 to the minus 4, 10 to the minus 5, 10 to the minus 6, and there didn't seem to be, for Veno-Benu, big differences between 10 to the minus 4 and 10 to the minus 6. So I'm not sure that, at least at the level of marrow, that pushing even deeper is going to lead to a lot more returns in terms of PFS, but we'll see.
Point that actually is what Amplify showed, because FCR or BR-FCR had a deeper response compared to AV alone. So, but in the end, the PFS was inferior to AV.
Yeah,
so.
not all MRD is the same. You can compare MRD as an endpoint, like between the same treatment, class, like 1 year versus 2 years of the same treatment. But it's clear that an MRD from chemo is not the same as an MRD undetectable state from Ven, and probably not the same from BTK, BCL2. They seem to be different.
Yeah.
You're watching the HeMonc Pulse Live, brought to you by Blood Cancers Today, a Fermetics property. For more content tailored to your therapeutic area, visit us at www.bloodcancerstoday.com.
Maybe we can have an additional discussion around MRD topic. One of the data from the Amplify study with the combination of acalabrutinib, venetoclax inducing cross-trial comparison compared to ibrutinib, venetoclax less deep remissions. That seems somewhat believable, but what does that mean practically? Would you suggest seeing the data as they are if we now get approval? It's already NCCN guideline listed acalabrutinib, venetoclax. Would you say, well, if the goal is to get as many as possible patients MRD negative, we need to do a triple combination for acalabrutinib-based treatment?
Did anybody else want to take that, or? I've been talking a lot. So I've been talking a lot. So I've actually started I'm in a rare period where I don't have a first-line trial to enroll on right now, so I'm actually doing commercial first-line treatment since the Celestial trial has closed to accrual. That's the sonrotoclax-Xanu combination. So I've actually been very pleased with, you get a new patient with CLL and they need treatment, and as opposed to just having the discussion about, okay, we're gonna need to figure out IV access and block out all this time in the infusion center, and here's what you need to know about infusion reactions, and then we'll get you in for the Ven ramp up. I can just prescribe the Ven, say, see you in a month, and then they generally are coming back feeling better already. Prescribe the Acala, see you in a month. They come back feeling better, and then by month 2 you can then talk about adding the Ven. The mutated patients seem to do really well